Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk. This will be the next in our series of CROI 2020 reviews. Today I'm going to focus on two abstracts that really relate to antiretroviral therapy safety and side effects. I do not have any conflicts or relationships to disclose. These are the two trials I'm going to cover today. First, IMPAACT 2010, a very exciting study because it is, as far as I'm aware, the first clinical data for TAF safety during pregnancy. And of course, there's been a lot of interest in dolutegravir safety during pregnancy in recent years as well. And then we will revisit the randomized controlled trial of various initial ART strategies called ADVANCE. And in this abstract, we are going to review primarily comparisons of cardiovascular disease markers and estimated risks, as well as diabetes risk, comparing efavirenz to dolutegravir, a topic of very hot interest because of all the studies in recent years showing the elevated weight gain and potential elevated or different metabolic outcomes with dolutegravir compared to other antiretroviral classes. And then below here are studies I will likely cover next week. So first, looking at this trial of dolutegravir combined with FTC-TAF or dolutegravir combined with FTC-TDF or efavirenz FTC-TDF during pregnancy. Again, a topic of a lot of interest because to date we have not had any clinical evidence for TAF safety during pregnancy, and because of all of the ongoing interest in dolutegravir safety during pregnancy, though I will make a couple of important notes and caveats about that. So this is the study design. This was a randomized open-label international phase 3 non-inferiority trial performed at 22 sites in 9 countries. The enrollment criteria, which I will highlight here, are antiretroviral therapy naive pregnant adults at 14 to 28 weeks gestation. So importantly, all of the ART initiated for pregnant women in this trial was done after week 14. So there was no analysis or evidence here for antiretroviral safety started during the first trimester. So that's just an important point to note about this trial. Another important note is that while the study enrolled ART-naive pregnant women, they were allowed to have taken ART within the 14 days prior to enrollment. And I'll note why I think that's important. Here are the primary endpoints: delivery, HIV viral load or RNA less than 200 copies, and then secondary endpoints, adverse pregnancy outcomes, and maternal and fetal adverse effects. Here is the results of the randomization. You can see 217 pregnant women randomized to dolutegravir plus FTC-TAF, 215 to dolutegravir FTC-TDF, and 211 to efavirenz FTC-TDF. Here are the baseline characteristics. I'll make a couple of notes here. You can see the 3 different study arms in the 3 different colored columns here. The median age in all the arms was about 26 to 27 years old. The majority were enrolled in sub-Saharan Africa. The median gestational age in weeks was 21 to 22. Again, all pregnant women in this trial enrolled in the second trimester, none enrolled during the first trimester. The median CD4 count and HIV RNA you can see here. One thing that caught my eye was how low the median HIV viral load was at enrollment. I didn't see or hear during the presentation any comments about this, but part of this, again, may be that a percentage listed here, about 80% of the women enrolled in the trial had taken some amount of ART within the past 14 days, and we know how potent and how rapidly integrase inhibitor regimens reduce the viral load, so that may have been part of the reason for the especially low enrollment viral loads in the dolutegravir arms. But even the enrollment viral load, the median viral load in the efavirenz arm was relatively low. So just a point to note. Again, you can see here around 80% of women enrolled in the trial who had taken some ART within the past 14 days, and even here 13 to 17%, depending on the arm, even had a suppressed viral load at the time of enrollment because of that short duration of ART they had taken. The median time on ART prior to enrollment was 6 days. So here are the key primary endpoint findings. So this is the proportion of participants with a viral load less than 200 copies at delivery. This is an intention to treat analysis. You can see here with dolutegravir-based ART. So this is a pooled result in the dolutegravir with FTC TDF and the dolutegravir with FTC TAF arm, 97.5% with suppressed viral load by that definition. And in the efavirenz FTC TDF arm, 91%. The virologic suppression at delivery was statistically superior with dolutegravir, and the time to viral suppression, not surprisingly, was also superior. But here, a key primary finding that viral load at delivery was statistically more likely to be suppressed with dolutegravir compared to efavirenz ART. Perhaps not surprising given what we know about tolerability of dolutegravir, potency, and likelihood of maintaining viral suppression from other studies. Here is the key safety data, which I think is really notable. So what you see here are the percent of participants with various adverse outcomes. And the really key thing to note here is that the dolutegravir FTC TAF arm here in blue was found to have lower proportions of participants with each adverse outcome, as you can see listed. And the overall conclusion of this part of the analysis was that adverse pregnancy outcomes were significantly less frequent with dolutegravir combined with FTC TAF as compared to dolutegravir combined with FTC TDF or efavirenz FTC TDF. An additional note not shown on the table is that neonatal death was significantly less frequent with dolutegravir FTC TAF as compared to efavirenz FTC TDF. That difference was not statistically significant when comparing the dolutegravir TAF arm to the dolutegravir TDF arm. Maternal weight gain, another topic of interest, is listed here. This is average weekly weight gain in kilograms. Of note, the dolutegravir FTC TAF participants were found to have a statistically higher average weekly weight gain as compared to participants in the other two arms. You can see here the conclusion that more weekly average weight gain occurred in those pregnant women taking dolutegravir plus FTC TAF compared to the other arms, though I have added this highlight that the clinical significance of this is unknown, and I did not see any report of assessments of potential metabolic complications like gestational diabetes or anything like that. So that is the finding, again, clinical significance unknown. So here are the investigator conclusions for treatment-naive women initiating ART during pregnancy. I would add the note that, again, remember this is during the second trimester of pregnancy, not first trimester. Viral load suppression rate at delivery is better with dolutegravir-based ART compared to efavirenz-based ART, and adverse pregnancy outcomes are less frequent with dolutegravir plus FTC TAF as compared to the other two treatment arms. So again, this is the first clinical safety data for TAF during pregnancy. TAF started the second trimester or later that we have seen. So I do think this is very notable, and hopefully in the near future we see data for TAF started either preconception or during the first trimester. Maternal weekly weight gain was greater with dolutegravir plus FTC TAF compared to the other arms, but again the clinical significance is unknown. And overall, this data supports the WHO, which is in the process of rolling out dolutegravir for all individuals with HIV, and suggests that TAF may become preferred over TDF during pregnancy, but guidelines have not yet changed to incorporate this data about safety for TAF in pregnancy, though I suspect they will in the future. So just to review, remember that right now, the Department of Health and Human Services perinatal guidelines do include dolutegravir as a preferred antiretroviral anchor drug during all trimesters of pregnancy and an alternative for women trying to conceive or who may conceive. Remember that TAF currently is listed as having insufficient data, but again, based on this trial and hopefully more clinical trials we will see, I suspect that those guidelines around TAF and pregnancy will be updated in the future, so stay tuned for more on that. With that, let's turn to a revisiting of the ADVANCE trial, which we reviewed at a prior ACC. This was another trial done in sub-Saharan Africa that looked at virologic and other outcomes of various initial ART strategies. Again, very highly relevant as the WHO rolls out dolutegravir worldwide. This particular analysis we are going to review focuses on differential changes to risk of cardiovascular disease and diabetes with dolutegravir as compared to efavirenz-based initial ART. Again, a topic of a lot of interest because we've reviewed studies that have found that dolutegravir-based ART leads to more weight gain as compared to efavirenz-based ART. But we have not seen much in the way of long-term cardiovascular or metabolic complications or outcomes based on that weight differential data. So every study that looks at metabolic and cardiovascular outcomes, I think, is of very high interest. But I will note that while this study adds to that literature, it is by no means definitive and there are some limitations. But let's dive in more detail. First, a review of the ADVANCE study and some updated 96-week data. So again, ADVANCE was a phase 3 randomized controlled trial performed in South Africa. The majority of participants were Black South Africans, about 60% were women, and the overall median baseline CD4 count was not substantially low. The participants were randomized to one of 3 initial ART options: dolutegravir with FTC-TDF, dolutegravir with FTC-TAF, or efavirenz with FTC-TDF. The key primary endpoint, which we're not going to focus on today and we have previously reviewed, is that the dolutegravir arms were found to have non-inferior virologic suppression outcomes with fewer discontinuations, and TAF led to fewer bone and renal adverse effects. But let's revisit the weight change and metabolic outcomes data. If we turn to this figure, and we've previously reviewed 48-week data, but I've updated this to 96-week data, you can see the 3 different arms: dolutegravir FTC-TAF, dolutegravir FTC-TDF, and efavirenz FTC-TDF. And then in the blue bars, you can see the change in weight from baseline to 96 weeks for female participants, and in the green bars for male participants. The most notable things here: number 1, you can see that those participants in the dolutegravir FTC-TAF arm gained more weight overall as compared to the other arms, and you can see that in all of the arms, cisgender female participants gained more weight than the cisgender male participants. I have shown you a bar graph here, but if you look at the abstract and the published data, what you can see here is another thing that I want to highlight. And I encourage you to go look at those line graphs over time. It's really notable that even at 96 weeks, for all of these participants, the change in weight appears to plateau, with the exception of female participants taking dolutegravir or TAF. Even at 96 weeks, for that specific group of individuals participating in the trial, weight continues to go up even at 96 weeks and does not appear to have plateaued yet. So I'd encourage you to look at that line graph available in the abstract and in the publications. Now, if we turn to this specific CROI study that assesses certain metabolic and weight change parameters, looking at the 2 dolutegravir arms compared to the efavirenz arm, with the goal of really making the comparison between dolutegravir and efavirenz. So pooling the dolutegravir arms and then comparing that data to the efavirenz arm. Here are a couple of general notes, and then we'll look at some more specific outcome changes. So the median percent change in visceral adipose tissue and subcutaneous adipose tissue was significantly greater at 96 weeks with dolutegravir FTC-TAF compared to either competitor. There was also a significantly greater rise in certain metabolic parameters comparing dolutegravir FTC-TAF to both comparators. And then you can see here some other changes noted, which all were higher for dolutegravir FTC-TAF. In some, they were higher than both other comparators, and in others only significantly higher compared to the efavirenz arm, but I'll let you read through those. Interestingly, the investigator noted that the dolutegravir FTC-TDF arm in these analyses seemed to be the most neutral in terms of changes over time, looking at lipid and these other parameters. Now, in this table, what I've summarized for you is by the 3 arms, the change in incidence of metabolic syndrome and the change in various estimated cardiovascular and diabetes risk predictor calculators using various tools. And so I'll just go into a little more detail on this. So first, looking at the 3 different arms, the percent of persons with metabolic syndrome at baseline, and then you can see the change to 96 weeks. The change was statistically greater in the dolutegravir FTC-TAF arm as compared to the other 2 comparators. So again, going back to what we knew that weight was greatest in this arm. It also appears that incident metabolic syndrome was also greater. And I forgot to mention it, but in previous analyses, we had also seen that incident obesity was higher. So it appears that over 96 weeks with dolutegravir FTC TAF, incident obesity and metabolic syndrome appears to be statistically greater compared to the other two arms. And then using various risk calculation predictor tools, the overall 10-year estimated MI risk using the Framingham calculator. So this is the percent risk here is the estimated percent 10-year risk by the Framingham calculator. You can see the estimated risk at baseline, and then you can see the change to estimated 10-year risk at 96 weeks. Of note here, using the Framingham calculator, there was no statistical difference comparing the three different arms. I haven't included it here, but they did do another calculation using something called the Q risk score, which was new to me. I had to look it up, but it's another cardiovascular risk estimator or calculator that incorporates more parameters than Framingham risk. And using that Q risk calculator, there was a trend towards higher risk in the dolutegravir TAF arm, but it did not fully meet statistical significance. And then using the Q diabetes risk calculator, which estimates 10-year diabetes risk, also was new to me, but that's what the investigators used. You can see here the estimated 10-year risk at baseline, which is relatively low, and then you can see the change here in estimated risk. And of note, using this calculator for estimated 10-year diabetes risk, that risk increase was greater in the dolutegravir TAF arm compared to the dolutegravir FTC TDF arm, and also, interestingly, was greater in the efavirenz FTC TDF arm compared to the dolutegravir FTC TDF arm. So some suggestion there that the estimated 10-year diabetes risk goes up more with dolutegravir TAF compared to dolutegravir TDF, and may also go up more with efavirenz TDF compared to dolutegravir TDF. So again, some suggestion that dolutegravir TDF may be the most neutral of the three options. So here's a summary of the findings. It appears in this trial that dolutegravir FTC TAF resulted in greater increases in incident obesity, visceral adipose tissue, and subcutaneous adipose tissue, as well as 10-year diabetes risk and incident metabolic syndrome compared to the other options. There was no difference in estimated risk of MI or coronary death using the Framingham calculator. There was a trend towards increased estimated cardiovascular risk using the other calculator, the Q risk calculator. But importantly, there are significant limitations to this analysis. The median age at enrollment in the trial was 31 years. So this was not what we consider to be an overall high-risk clinical cohort for diabetes or cardiovascular disease, and may not be generalizable to all of the individuals we see in clinic, especially those in older age brackets. Again, weight gain among women has not plateaued even at 96 weeks, and these models do not account for weight gain after 96 weeks. So, I think that we've seen some consistency in data in recent years that dolutegravir, especially when combined with TAF, may lead to higher rates of weight gain, especially for certain individuals. We've reviewed that data at prior ECHO and ACC meetings. What we do not have a clear understanding of is the long-term metabolic implications or rates of complications. So I think all data like this is welcome. I do think this data is limited by these specific factors that I have put here. And I do hope to see further clinical studies looking at these long-term cardiovascular and metabolic complications with various regimens, and hopefully even longer-term follow-up. So what is not known is how this should impact our clinical decision-making in our practice, and this has not really affected any of the guidelines in terms of which regimens to start as far as I am aware. So I will let you chew on this data and think about how you will incorporate it into clinical decision-making in terms of initial ART, as well as clinical counseling for patients initiating their first ART regimen. And I will wrap it up there.
Thank you for watching this edition of the Mountain West AETC Project ECHO Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.